Hello, everybody. Thank you so much for having us here. I know we talked a lot about how we need collaboration, how we need to break down silos, but how do you do that? It's a great idea, it's a great concept, but how do we achieve collaboration and unity in approaching mental health? Well, Aubree and I have been in this space for quite some time. We're going to share the home team model with you. This model was built from the ground up for people who are living on the streets with severe mental illness and can't access anything, not really taking care of their basic needs, disconnected from community. How do you transform this life? And the solution, I heard the word ecosystem, and ecosystem is a very important word because an ecosystem is completely integrated. And we have spent the past 5 years doing that. I'm going to introduce my co-presenter, Aubree Lovelace, and I'm Shayan. We've been with the home team for quite some time, and we have an exciting presentation for you today. Let's see how street psychiatry, how every single skill set in the mental health system comes together to build an ecosystem of care. Let's do a quick introduction. These are two entirely different populations. The medical model is essentially designed for people who are housed. All of our standards of care, treatment plans, everything that we're taught can only really be implemented if you have the psychosocial foundation to implement that treatment plan. People experiencing homelessness do not have that foundation, so everything starts falling apart. This is because the mental health system is missing parts of itself that need to be developed over time, and we actually have done that. The key that's been missing over here are field-based mental health services that actually complete the entire traditional mental health system. Why is it important for us to have an integrated system that actually meets people where they're at? Because of this. This is the homeless mortality rates that LA County puts out every couple of years. In 2023, these are the results that came out. More people are dying from drug overdose, heart disease, traffic-related injuries, homicides, and suicides. But the key part over here is that the average age of death is actually between 40 to 50 years of age. So people are dying at a younger and younger ages. And not only that, more and more of them are dying every single year. The streets are getting more dangerous, drugs are getting more powerful, crime is going up, and people are getting older. So let's take a look at the traditional mental health system and see how it addresses the needs of people experiencing homelessness. What is the mental health system? It's basically a collection of different levels of care. What are levels of care? An outpatient level of care would be like your brick and mortar clinics, primary care clinics. Your residential level of care will be your housing sources, board and cares, treatment facilities where you can both live and get treatment. Inpatient facilities are your traditional inpatient units, and emergency rooms are your ERs. These are different levels of care providing different intensities of services across the mental health system. Well, it works well if you're housed or you have support networks that can actually help you navigate that. But if you're experiencing homelessness, can you walk into an outpatient clinic and get stabilized? Probably not. It might be on the other side of the county. Too many barriers. Can you walk into a board and care and get housed right away? No, you need medical clearance. You need someone to write an affidavit of support. You need a physician's report. You need funding. Too many barriers. What ultimately happens is people start decompensating on the street, moving further and further away from resources, deeper and deeper into homelessness. Crisis response starts taking place, and then you start getting launched off to the ER, where inpatient beds do not grow on trees, so you might get recycled right back to the street because there's nothing to really move you forward to get treatment. But let's say the stars align, you're very ill, and a bed is available. When you go to an inpatient unit, what happens? You're there for maybe a couple of days, a week, maybe 2 weeks. Is this enough time to transform someone's life who's been on the street for decades? It is not. You can't really change someone in that setting. They're there against their will. It's an involuntary detainment. People just want to get out. It's not the best place to build rapport and convince someone that they need to trust you. People are there against their will, and one of their main concerns is to get out. But even if you are able to get someone into a placement, let's say they agree, I trust you, doctor, I will go to this board and care. That is a very difficult place to be. Someone might not have the skills, the abilities to manage the stress that comes with moving into a new place, living around strangers you've never met before. It's a big life transformation, and there is a very high risk of someone falling out and ending up right back to the street. What happens if you stay on the street for too long and you're mentally impaired and possibly using substance use? You start cycling in and out of the jails as well. So this is the reality of our mental health system, where you have nothing but barriers and revolving doors. I have consent to share some images from real home team clients. I'm going to share. This is a real individual that we were working with. This person was trapped in revolving doors and faced nothing but barriers on the street for many, many years. It's a perfect, and also at risk for being incarcerated because local businesses were starting to make complaints with law enforcement. This person, barriers and revolving doors, and ultimately was trapped in this entire setup. How do you fix this? How do you really go to a system that actually works a little bit better? What you really need is a team that actually acts as an adapter with the streets for people who are experiencing homelessness and also understands the traditional mental health system. And this is the space where field-based mental health teams reside, and they act as the connective tissue that links the streets to the traditional mental health system. But just being a team is not enough. What you really need is to build partnerships across all levels of care, build clinical relationships with outpatient levels of care, with housing facilities, with inpatient facilities, and with emergency rooms. And that is the space, and that's kind of what the home team has spent doing for the past 5 years. We're not just a team on the street, we have partnerships across all levels of care, and this is what we call an integrated recovery-driven ecosystem of care. It's a system within the system, one that's not built on contracts, but one that is built on relationships with people coming together with a unified vision. And I'm gonna hand it over to Aubree to kind of explain a little bit more about them.
All right, good morning, everybody. So an overview of the home team. So we have made many transformations over the years, but in the last few years, as Shayan mentioned, we've kind of solidified our place here with the Department of Mental Health. So our focal population is people experiencing homelessness, street homeless, bordering on the grave disability side, right? They can't attend to their daily needs. They're not feeding themselves. They're not they can't shower. Obviously, they have no shelter. And so the goal for us was, there are a lot of outreach teams out there, right? Some of you are part of, street medicine teams. There's a huge outreach system within Los Angeles County, but nobody has sort of the specialty care and kind of integration already into the Department of Mental Health, who has access to a variety of things. So our goal is, initial outreach. We're gonna bring clients whatever they need, wherever they are, to get to build a rapport, to get them interested in services, to get them invested in their care. So we'll be bringing food, clothing, tents, hot meals and things like that. And the goal is, from there, our teams are multidisciplinary, which we'll talk about in a minute. And so trying to figure out, the relationship, who on our team is going to have that relationship with that individual. Might it be the nurse who can offer some kind of medical care? Might it be a peer who can offer some lived experience and some, continuity there? And then eventually bring in our psychiatrists, our nurse practitioners to get individuals onto psychotropic medications when we can. And then, as Shai mentioned, right, we had to build these huge relationships with all of the different entities within the county to get our people off of the streets and into the appropriate placements. So this is just a little snapshot of the picture. So our teams, we have 18 teams serving the entire county of Los Angeles, and they're built with clinical supervisors, there's clinicians, there's RNs, we have community workers, medical caseworkers, psychiatrists, and nurse practitioners. So we're at approximately, so a couple years ago we were much smaller. We were around the staff of 60, and we only had one team that had a psychiatrist on it, which was Shai, who was in Skid Row and serving Service Area 4. And now we are over 200 staff, closer to 230 staff, 15 full-time psychiatrists and psychiatric NPs. We have residents, we have fellows that come along with us.
This is where we start integrating higher levels of care and actually accessing acute care, but not just sending people to the hospital. We actually have our own partnered hospitals where we went and just made lunchtime pitches to bring them into our ecosystem and said, if we admit someone to you, don't send them out. You better admit them to the inpatient unit. We will come to the hospital and stabilize this individual with you. While you do the treatment, we will continue the housing. And getting the person to the hospital itself is a huge thing, which Aubree can comment on.
Yeah, so I think anybody who's worked in the mental health sector with people experiencing homelessness, getting somebody to the hospital and making it stick is tricky, right? So the other thing that we see a lot of times is that we might think somebody needs to go to the hospital. We might think they meet criteria for involuntary treatment, and they're not going to get on the gurney. And so that's another kind of specialization home has taken on, which is we have trained our staff to be able to assist individuals with getting on the gurney. So we will use physical restraints and trainings to assist in that, because what we don't want to have happen is somebody we know is going to die on the street and we just leave them there. And we also know that it's not an appropriate call for law enforcement. It's not an appropriate call for the fire department to come assist with that, right? There's things that they're our client and we want to be responsible for them, and we want to do as much as we can to be kind of trauma informed in the work that we do with them. So we've ensured that all of our staff with home, and we're trying to spread it around the department more, are able to do this to effectuate these holds.
And once stabilization has happened, we actually have the individual return to housing. We will actually do the discharge planning before we even admit someone. So when they're stabilized, they go right into housing. It's a lot easier to get people housed when they're coming out of a hospital because they're doing a little bit better. They can make better decisions. We'll move them directly into housing. Our return to street rate with our partnered hospitalizations is only 14%. 86% of our folks remain housed after an inpatient stabilization, and then we will continue working towards reintegration. The hospital is just a small blip in someone's recovery, but a critical one that can help us move forward. However, sometimes this is still not enough. People will still fall out, they will elope from their treatment facility, they will stop treatment, they will end up back on the street. We will try the hospitalization maybe a couple of times to try and move forward. And in majority of cases, between the streets and the hospitals, we're about 95% successful. However, in some instances, despite our best efforts, every pathway gets blocked because the individual is that impaired. In those situations, we still have options because the Board of Supervisors have authorized the home team to start conservatorship proceedings from the street without using hospitalizations. Not all conservatorships are life-threatening where it needs to be done in the hospital. Some of them can be managed outside of a hospital, and we spent the past 4 years building that pathway. If you do a conservatorship in the traditional setting, how long does it take before someone makes it to an open residential facility where they can integrate with the community? 2 years. 2 years. Yes. Got it. Perfect. Well, I'm running out of time, but just wanted to show the last part. Is that this is what our final model looks like, but very quickly I'll show you a couple of success stories to show you what our model looks like. Here's an individual who we began working with. 2 months later, an entire new individual. This is the kind of stuff that we're looking at. I'll go through them very quickly so you can see exactly the type of stuff that we're talking about. And this last one, this is a woman that we actually flew back to France to reunite with her mother as well. So we are doing international family reunification. With that, thank you.